Bismillahirrahmanirrahim. On to the third session of our 100-point sessions. So now we are going to talk about diaphragm. We previously have seen the diaphragmatic apertures, and now we'll see the diaphragm and the movement of diaphragm basically. Paralysis of half of the diaphragm may result from the injury or operative division of the phrenic nerve of the same site. So there is an ipsilateral damage whenever there is damage to the phrenic nerve, and there will be hemidiaphragmatic paralysis. It can be detected radiologically. There will be paradoxical movement. Dome of the diaphragm of injured side is pushed superiorly by the abdominal viscera during the inspiration instead of descending, as you can see here. When this part of the normal functioning diaphragm will be pushed downwards, the gastric viscera that is present over here, or the abdominal viscera, they will be pushing the paralyzed side upwards. So this side on inspiration will be moving upward instead of moving downwards. So this is a paradoxical movement. Then we have phrenic nerve. So it arises from the anterior primary rami of C3 to C5 nerve and lies in front of the anterior scalene muscles. Okay, scalene muscles are in the neck. Phrenic nerve runs anterior to the root of the lung, whereas the vagus nerve runs posterior to root of lung. Remember this point. Phrenic nerve is running anterior to root of lung, while the vagus nerve is running posterior to the root of lung. So here we have the phrenic nerve running anteriorly, and the vagus nerve is over here, that is running posterior to the root of lungs. Okay. Then innervates the fibrous pericardium. The phrenic nerve innervates the fibrous pericardium, the mediastinal and diaphragmatic pleurae, that is sensory innervation to these structures, and the diaphragm of the motor and its central tendon for sensory. Okay, pardon me. So phrenic nerve is innervating fibrous pericardium and the mediastinal and diaphragmatic pleurae, which is mainly the sensory innervation, and the motor supply to the diaphragmatic musculature, and then again the sensory supply to the central tendon. Okay. Then we have diaphragmatic ruptures. Talking about diaphragmatic ruptures, diaphragmatic injuries are relatively rare and result from either blunt trauma or penetrating trauma. Presently, 80 to 90% of the blunt traumas rupture result from the motor vehicle crashes. The majority, 80 to 90% of the blunt diaphragmatic ruptures have occurred on the left side. Why so? Because there is relative protection by the liver on the right side. The blunt trauma typically produces large radial tears measuring 5 to 15 centimeters, most often at the posterior lateral aspect of the diaphragm. So the radial, there is laceration over there, and due to the diaphragmatic rupture, the viscera are moving upwards. Okay, then we have the stomach and colon occupying 2/3 of the hemithorax, and the left lung compressed against the superior mediastinum, and here we have the pneumothorax of the apex of the left chest. Then what is congenital diaphragmatic hernia? Intestine protruding through the hole in the diaphragm. So hernia of stomach or intestine through the posterior lateral defect in the diaphragm, foramen of Bock-Talek. It is seen in infants, and the mortality rate is high because of the left lung hypoplasia, because you know that if congenitally the viscera are present in the hemithorax, so the lung will be compressed, and if the lung is compressed, so it will not find the room to expand and grow to the normal size, so there will be pulmonary hypoplasia, and resultantly the mortality rate is very high in the case of infants. Intestine protruding through the hole in the diaphragm. Then what is the point of sliding hernia? So hiatal hernia is of like two main types. One is the sliding hernia and other is paraesophageal. I guess no, they have not written about that, so we'll talk about later. So a sliding hiatal hernia, which occurs in the individual past middle age, is caused by the hernia of the cardia of the stomach into the thorax through the esophageal hiatus of the diaphragm. This can damage the vagal trunks as they pass through the hiatus and resulting in the hyposecretion of the gastric juices. Why will there be a hyposecretion of the gastric juices? Because the vagal trunks which are passing through the esophageal hiatus can be damaged. So here you can see a picture. This is stomach and this is the hiatal hernia above the diaphragm. This is diaphragm over here, gastroesophageal junction is right over there, and esophagus is over there. So cut away view of the hiatal hernia, then we have the diaphragm and stomach. So remember these things, and moving forward. So what is paraesophageal hiatal hernia? Paraesophageal hiatal hernia. So in that paraesophageal hiatal hernia, the cardia is right in its place. Pardon me for that. So we're talking about paraesophageal hiatal hernia. So in that case, the cardia will be on its place, but maybe the fundus herniates outwards and just come parallel to the esophagus, and that thing is called as paraesophageal hiatal hernia. Moving forward to the cardiac hypertrophy. So left atrial enlargement hypertrophy secondary to the mitral valve failure may compress the esophagus and manifest as dysphagia, difficulty swallowing. So that is left atrial, because left atrial is most posterior structure of the heart that is lying adjacent to the esophagus. So left atrial enlargement hypertrophy secondary to the mitral valve failure may compress on the esophagus and manifest as dysphagia, that is difficulty swallowing. It may be observed as a filling defect in the esophagus by the barium swallow on the lateral thoracic X-ray. Then we have X-ray of the thorax, that is posterior anterior projection. So you have to remember, like moving from here all the way to this direction. what are the structures which we encounter? This is the right side, and here we have the left side. So on the right side, the most superior structure is superior vena cava. Then we have right atrium. Then there may be inferior vena cava as well. On the left side, from downwards, from below upwards, if we are rotating in this direction, so moving from below upwards, we'll find left ventricle. Firstly, then the apex of heart will be there. Then we'll come across the pulmonary trunk, and then arch of aorta will also be seen. So right border is formed by superior vena cava and right atrium, while the left border is formed by the aortic arch, pulmonary trunk, left auricle, and the left ventricle. Auscultation of the heart valve. So these are the four main points for the auscultation. So this one is the right second intercostal space on the parasternal what cell? I don't know. So parasternal location. So auscultation point for the aortic valve. This is A1 location. Then we have pulmonary location. Then this one is the tricuspid area, and here we have the mitral area. So the left second intercostal space, parasternal location, it is the pulmonary area. Then the left fifth intercostal space is the MCL, that is myocardial, is a mitral valve. What is MCL? Mid clavicular. Okay, good. So left fifth intercostal space in the mid clavicular line we have the mitral area, and on the left fifth intercostal space in the parasternal location we have tricuspid area, auscultation position of the tricuspid valve. And here you can see in a zoomed picture, the aortic valve is present over here. Like this is the aortic valve, and then here is the pulmonary valve. This is tricuspid valve, and this is the mitral valve. Moving forward, auscultation site for the mitral and aortic murmurs. We have seen these things in the UVERT sessions as well, but let's revise them once again. So right upper sternal border, the systolic murmur is aortic stenosis, that is heard in 8% of the cases, I guess. Then the left upper sternal border, the systolic murmur is mitral insufficiency. Why is it over there? Because it is radiating to the axilla. Okay, so then at the apex we find mitral stenosis and aortic insufficiency. This is not a very good diagram per se, because there was a better diagram in the UVERT series. I guess it was in the first part of the fourth block, maybe, or maybe the second part. So it was in the fourth block. So go check that out, please. So right lower sternal border and systolic tricuspid insufficiency is over there. Heart murmur is heard downstream from the valve. Stenosis in the orthograde direction from the valve, insufficiency in the retrograde direction from the valve. So orthograde, stenosis, if this is the mitral valve maybe is over there. So this is moving downwards. So orthograde direction means downward. Okay, in the away from the valve, and insufficiency retrograde is directed retrograde, like away from upward, the location of the valve. So retrograde is moving to the axilla, like mitral insufficiency murmur is heard in the axilla. So stuff like that. Conducting system of the heart. What is the conducting system of heart? Sinoatrial node is the pacemaker, site where the contraction of the heart muscle is initiated, that is the pacemaker of the heart, situated in the upper part of the sulcus terminalis, just near the opening of the superior vena cava. Atrioventricular node, the AV node receives impulses from the SA node, situated in the lower part of the atrial septum near the coronary sinus. Okay, so it is located near the coronary sinus, and the SA node is located near the opening of the superior vena cava. Then atrioventricular bundle of His descends from the AV node to the membranous portion of the ventricular septum, where it divides into left and right bundle branches. The right bundle branch passes down to reach the moderator band, right ventricle, and the left bundle branch passes down the left side of the ventricular septum. What is blood supply of the heart? Right coronary artery. So right coronary artery, it supplies the major part of the right atrium and the right ventricle. It anastomoses with the marginal branch of the left coronary artery posteriorly. Branches: anterior cardiac branches supplies the right atrium. Nodal branch supplies the SA node and the AV node. The marginal artery supplies the right ventricle, and the posterior interventricular artery supplies diaphragmatic inferior surface of both the ventricles and posterior 1/3 of the interventricular septum. So the anterior cardiac branches, we are talking about the right cardiac artery. So the right cardiac artery gives following branches: anterior cardiac branch which supplies the right atrium. The nodal branch will give SA node and AV node branches to SA node and AV node. The marginal artery supplies the right ventricle, and posterior interventricular artery supplies the diaphragmatic surface, inferior surface of both the ventricles, right and left, and posterior 1/3 of the interventricular septum. And this is the branch which determines the dominance of circulation. Most of the people, like I guess 65 to 75% of the people, they have right dominant circulation, in which the posterior interventricular artery is originating from the right coronary artery, but it may also originate from the left circumflex branch of the left coronary artery. So in those people, we say that they have left dominant circulation. Left coronary artery branches: anterior descending interventricular artery, the most common place of myocardial infarction, descend in the anterior interventricular sulcus and provide branches to the anterior heart wall, anterior 2/3 of interventricular septum, and the bundle of His. and the apex of heart. Circumflex artery winds around the left margin of the heart in the atrioventricular groove to anastomose with the right coronary artery posteriorly and supplies the left atrium and left ventricle. So circumflex artery supplies the left atrium and left ventricle. Blood supply of the conducting system. For the SA node, the artery is right coronary artery. For AV node, the artery is again the right coronary artery. And for the AV bundle and the moderator band, the artery is left coronary artery. So for the pacemakers, for the pacemaker like SA node and for the AV node, we have blood supply coming from the right coronary artery. And for the AV bundle and the moderator band, the blood supply is coming from the left coronary artery. Supply of the thoracic viscera, thorax, artery, internal thoracic and thoracic aorta. Parasympathetic innervation, preganglionic, that is DMN of vagus nerves. What's that? DMN, deep motor neurons, or I don't know. Vagus nerve, cranial nerve 10. Preganglionic fibers are coming from the dorsal motor neurons. Dorsal motor neurons. Is that anything? I don't think so. So DMN of vagus nerve branches, cranial nerve 10, and postganglionic are the terminal ganglia. The terminal ganglia. Okay. So I don't know what that means. Preganglionic are from the dorsal motor neuron of the vagus nerves. Deep motor neurons maybe. Okay, I don't know. I just can't crack it right now. Sympathetic innervation. Preganglionic is intermediolateral column of the T1 to T4. So in the spinal cord, like this is the butterfly of the spinal cord inside, like this one, and this is the spinal cord. So in the spinal cord, in the T1, basically in the thoracic segments, we have another segment that is this one. So that is called as intermediolateral column of the spinal cord. There the preganglionic and the postganglionic sympathetic fibers are in the sympathetic trunk of T1 to T4 ganglia, and the thoracic splanchnic nerves are providing the sympathetic innervation. So for the parasympathetic fibers, what is the preganglionic segment? That is dorsal. Okay, I just still can't understand that. Dorsal of the vagus. Okay, that's dorsal motor neuron of the vagus that is located in the medulla. So there is a nucleus of the vagus nerve in the medulla that is called the dorsal motor neuron of the vagus. Okay, that is CN10. So CN10 is the preganglionic branch, and the postganglionic there is terminal ganglia. Like for the parasympathetic, you know that the preganglionic fibers are very long, while the postganglionic fibers are small because the ganglia are located on the target organs. So that is how the preganglionic fibers are originating from the dorsal motor neuron of the vagus, and the postganglionic are the terminal ganglia. Then moving to the sensory innervation, that is dorsal root ganglia of the T1 to T4. DRG is the dorsal root ganglia, and referred pain goes to the left arm in the case of myocardial infarction. Let's talk about fetal circulation. Fetal circulation is very, very different from the adult circulation. So fetal circulation involves three shunts. First one is ductus venosus, that is located over here. We'll see the zoom picture soon. Then second one is ductus arteriosus, that is the common one which we find in the patent ductus arteriosus as well. I think I need to change the color of my pencil to some bright color. So this one is the patent ductus arteriosus or the ductus arteriosus site, and the third one is foramen ovale, that is present over here. There we find the foramen ovale. So let's see these structures. So the first one is over here. It is a shunt which is suppose these are the umbilical veins, basically umbilical veins which are carrying the oxygenated blood. The oxygenated blood is shunted directly into inferior vena cava by ductus venosus. So initially the umbilical veins are going to the liver, but the vein that shunts the blood from the umbilical vein directly into the inferior vena cava is the ductus venosus. What is ductus arteriosus? Ductus arteriosus is the connection between the aorta, the arch of aorta, and the pulmonary artery, and that shunts the blood from the right heart directly into the aorta, because the right heart gets oxygenated blood during the fetal life. And then we have the foramen ovale. Foramen ovale also causes the blood from the right heart that is oxygenated to be shunted into the left heart that is lesser oxygenated, because the lungs do not contain any oxygen in the intrauterine life. So there must be a connection between the right heart and the left heart. So two connections are there. First one is the foramen ovale, and second one is the that is ductus arteriosus. So these two connections are between the right and left circulation to cause ample oxygenation. Then after birth, the closure of ductus venosus will form ligamentum venosum. They ask you about this one, that what is the remnant of the ductus venosus. So that is ligamentum venosum. Closure of ductus arteriosus produces ligamentum arteriosum, and closure of foramen of veil produces fossa ovalis, closure of umbilical arteries and umbilical vein. So they will also become closure of umbilical arteries and umbilical vein, and all of them will become ligaments. So I don't remember the exact confirmation. I guess that confirmation will come later on in the abdominal sessions of this book. So, but remember that all these three shunts are needed to be closed. If any of them is patent, like most commonly the arteriosus is, this ductus arteriosus is patent, that is called as patent ductus arteriosus. So that can result in non-cyanotic congenital anomaly of the heart. Yes, so this is a non-cyanotic congenital anomaly, so that can result in response to this one. Cardiovascular abnormalities, atrial septal defect. So atrial septal defect, it is less frequent than the ventricular septal defect, firstly. Secondly, okay, so ASD is less frequent than the VSD. It results from the failure of the foramen ovale after birth, failure to closure of the foramen ovale after birth, failure of the septum primum and septum secundum to fuse. So there are two septums. If the septum primum and septum secundum does not fuse together, so resultantly we'll have the patent foramen ovale. Postnatally, atrial septal defect result in the left to right shunting between the right and left atrium and non-cyanotic condition. So that is a non-cyanotic condition. ASD, VSD, patent ductus arteriosus, and coarctation of aorta. That is not basically a condition per se, but okay, so you just keep them three: ASD, VSD, along with the patent ductus arteriosus. These are non-cyanotic congenital anomalies of the heart. If it is small, it has no clinical significance. If it is large, necessary surgical repair, because in the future it can result in paradoxical embolization from the venous circulation to the brain. Okay, so this is a normal heart, and then heart with the atrial septal defect. The blood is shunted to the pulmonary circulation as well as to the left heart directly. And you know that in the adult people, the right heart is receiving the non-oxygenated blood. If the non-oxygenated or deoxygenated blood is shunted directly to the left heart, which must receive oxygenated blood to be supplied to the body, so the body's oxygenation level can decrease in the long run. Then we have ventricular septal defect. It is more common. Ventricular septal defect is the most common of the congenital heart defects. It may be found in the membranous part of the ventricular septum and result from failure to fuse the membranous portion with the muscular portion of the ventricular septum. In this case, present left to right shunt, right ventricular hypertrophy. In this case, present left to right shunt will cause right ventricular hypertrophy, and again non-cyanotic. So this is also a non-cyanotic condition. So what is happening in this case, that we have a ventricular septum over there. So the left ventricle will pump the blood into the right ventricle, and when the right ventricle will get this amount of blood, so this is an unusual amount of blood and unusual pressure of the blood for the right ventricle. So right ventricle will undergo hypertrophy. Ventricular septal defect is an abnormal opening in the wall between the two ventricles, and this is ventricular septal defect over there. And here you can see in this picture, I guess you are visualizing somehow the right ventricular hypertrophy. Necessary surgery for the large defect. Okay, for the large defect we need a surgery. Now what is tetralogy of Fallot? Tetralogy of Fallot or Fallot, whatever you may call it. It is a congenital heart disease responsible for about 9% of all the cardiac defects. It is cyanotic heart disease, right to left shunt with the following abnormality. So it is a cyanotic one. So the first cyanotic heart defect which we are studying, or which we are going to study right now, is the tetralogy of Fallot, or TOF. Pulmonary stenosis, most important. So there are these four things are tetralogy, like four things together are found in the symptom. The first one is pulmonary stenosis, as you can see in this picture, that the pulmonary artery has undergone stenosis. It is most important. Then there will be an overriding aorta. So there will be a membranous interventricular defect. So there will be a VSD and an overriding aorta that will be overriding both the ventricles, right and left ventricle. So these are the right and left ventricle, and the aorta is overriding both of them, as you can see in this picture. The aorta is overlying both of these ventricles, so that is called as overriding aorta. Receives the blood from both the ventricles. Membranous interventricular septal defect and right ventricular hypertrophy that develops secondarily, that will also be seen. Surgical treatment is necessary. What is patent ductus arteriosus? So here we have a patent ductus arteriosus in this picture, and patent ductus arteriosus, mixing of blood from the aorta oxygenated in the pulmonary artery, unoxygenated blood. So there will be mixing of the oxygenated and deoxygenated blood in the aorta because of this ductus arteriosus. The patent ductus arteriosus, it results from the failure of ductus arteriosus, the connection between the pulmonary trunk and aorta, to constrict and close after birth. Prostaglandin E and low oxygen tension sustain the patency of the ductus arteriosus in the fetal period. Patent ductus arteriosus is common in premature infants and in the cases of maternal rubella infection. Okay, so PDA will be seen in it is a classic triad of the rubella, which includes cataract, sensory neural hearing loss, along with the patent ductus arteriosus. Left to right shunt increases the pressure in the pulmonary circulation, pulmonic hypertension, and is a non-cyanotic condition. So patent ductus arteriosus is a non-cyanotic congenital anomaly. Among the cyanotic, so let me enumerate them. The non-cyanotic are VSD. Okay, so it will be very hard to write them all. So listen kindly. First one is VSD, ASD, and the patent ductus arteriosus. These three conditions, along with the coarctation of aorta, if you can call it a congenital anomaly, which normally you can't. So these four conditions are non-cyanotic conditions. Talking about cyanotic, the first one is the tetralogy of Fallot. Second is transposition of great arteries. Third one is that is that was transposition of great arteries. Then we have, give me a second. These are the conditions. So the cyanotic ones are truncus arteriosus. Then we have transposition of great arteries, tricuspid atresia, then tetralogy of Fallot, and total anomalous pulmonary venous return. So these five conditions are cyanotic one, and non-cyanotic are the ASD, VSD, and the patent ductus arteriosus. Then we'll talk about the coarctation of aorta. So what is coarctation of aorta? It results from the congenital narrowing of the aorta distal to the offshooting of the left subclavian artery. Okay, when the left subclavian artery, like over here, when it is offshooted, so after this there can be a congenital narrowing of the of the aorta. The cardinal signs are higher blood pressure in the upper limbs compared to the lower limbs. Coarctation of the aorta result in the intercostal arteries providing the collateral circulation between the internal thoracic artery and the thoracic aorta. So there will be a collateral circulation between the internal thoracic artery and the thoracic aorta to provide the blood supply to the lower part of the lower parts of the body. Coarctation of aorta characteristic X-ray picture is this one. So serrated appearance of the inferior border of the rib notching is seen in these cases. So if you could see this thing, it's not a very good picture for rib notching. So I guess I should Google it. Maybe we find a better picture. Rib notching. So rib notching is seen over here. Yes, that is a good picture. So if you can appreciate this picture. So here you can see the serrated appearance of the inferior margin of the ribs, that is called as rib notching. Moving back, so we were talking about rib notching. So let's zoom it out. Yep. Then we have total thoracic aortic aneurysm. So what is the thoracic aortic aneurysm? The aneurysm of the aortic arch compresses the left recurrent laryngeal nerve, leading to the coughing, hoarseness, and the paralysis of ipsilateral vocal cord. It may cause dysphagia, difficulty in swallowing, resulting from the pressure on the esophagus, because the descending aorta is located posterior to the esophagus, and it may compress the esophagus that is located anterior to this one. So that may result in dysphagia resulting from the pressure on esophagus, and dyspnea, difficulty in breathing, resulting from the pressure on the trachea, root of the lung, and the phrenic nerve. Aneurysm of thoracic aorta may compress and tug on the trachea with each cardiac systole, so that the aneurysm can be felt by palpation by palpating the trachea and the sternal notch. So you can palpate the trachea and sternal notch, because this aneurysm will be tugging on the trachea with each heartbeat. So this is thoracic aortic aneurysm, and you can see it on the X-ray as well. Moving forward, we have abdominal aortic aneurysm. So this is it is the localized dilation of the aorta. It typically happens just above the bifurcation at the level of L3 and crossed by the third part of the duodenum. Okay, it is crossed by the third part of duodenum. Okay. At the level of L3 and crossed by the third part of duodenum is crossing anterior to this one. The pulsations of large aneurysm can be detected by the to the left of the midline at the umbilical region. Acute rupture of the abdominal aortic aneurysm is associated with severe pain in the abdomen or back. Mortality rate is nearly 90% because there is excessive bleeding, right? Because all the blood that is coming from the left ventricle is going to the aorta, and the abdominal aorta is a continuation of that. So there will be excessive intraperitoneal or retroperitoneal. There will be retroperitoneal, sorry. So there will be excessive retroperitoneal bleeding inside this. So that internal bleeding can cause mortality rate to be as high as 90%. Surgeons can repair aneurysm by opening it and inserting a prosthetic graft if they get the time to do that. Point number 29 is about bronchopulmonary segments, aspiration of the foreign body. So aspiration of the foreign body, inhalation of the foreign body, for example, pins, parts of the teeth, screws, nuts, bolts, toys, into the lower respiratory tract is common, especially in children. More likely to enter the right pulmonary bronchus and pass into the middle or the lower lobe bronchi. So they can pass either into the middle or lower lobe bronchi depending on the position of the patient. If the vertical position of the body, like patient is standing or sitting, so the foreign body usually falls into the posterior basal segment of the right inferior lobe. If the patient is in the supine position, then it can go to the middle lobe as well, I guess, something like that. So yeah, but if the patient is in the vertical position, the foreign body usually falls into the posterior basal segment of the right inferior lobe. Let's talk about right lung. There are 10 bronchopulmonary segments on the right side. So the first one is apical, superior lobe, middle lobe, and inferior lobe. We know that the right lung has 3 lobes: superior, middle, and inferior. The superior lobe has apical, anterior, and posterior segments. Middle lobe contains lateral and medial segment, like lateral, fourth one, this is lateral and this is the medial segment. Then the inferior lobe contains superior, anterior basal, posterior basal, lateral basal, and the medial basal segment. So these are the segments which are found in the inferior lobe. What are the left lung lobe? So it contains 9 bronchopulmonary segments. So the superior lobe, so there are only 2 lobes on the left side, that is superior lobe and the inferior lobe. So superior lobe can contain apicoposterior, anterior, superior lingular, and inferior lingular segments. So apicoposterior, one, anterior, this one, then superior lingular and the inferior lingular lobes. Inferior lobe contains superior, anterior basal, posterior basal, lateral basal, and the medial basal segment. So these are the segments which are present in the inferior lobe. After that, we have lung diseases. Number one is pneumonia. We are talking about the 30th point. So pneumonia is an inflammation of the lung caused by an infection of the infection or the chemical injury to the lungs. 3 common causes are bacteria, viruses, and fungi. Cough symptoms include cough, chest pain, fever, and difficulty in breathing. Chest X-rays, areas of opacity seen as white. So these are the area of opacity in this X-ray, this whole thing. So here you can see the area of opacity compared with the normal left lung. So this is left and right. So there we have opacity, area of opacity on the left lung, on the right lung, I'm sorry, in the right lung. So area of opacity seen as white on the lung parenchyma and enlargement of the bronchomediastinal lymph nodes. Bronchomediastinal lymph node, I guess there they can, no, that's not the lymph nodes. So but bronchomediastinal lymph nodes or mediastinal widening can be seen. If you can see in this picture, so mediastinum has become this white. Normally it is not this white, so there is widening of the mediastinum as well. Moving down to the bronchogenic carcinoma. So bronchogenic carcinoma arises in the mucosa of large bronchi, produces as persistent productive cough or hemoptysis. So the bronchogenic carcinoma, it produces are as persistent productive cough or hemoptysis. So basically it produces symptoms which are persistent productive cough or hemoptysis, early metastasis to the thoracic bronchomediastinal lymph nodes, hematogenous spread to the brain, bone, lung, and renal gland is also common. A tumor at the apex of the lung is called as Pancoast tumor, may result in the thoracic outlet syndrome and can cause the Horner syndrome, and also it can also cause the compression of the lower roots of the brachial plexus, and that is called as Klumpke's paralysis. So remember that one as well. So here you can see that the bronchogenic carcinoma, epidermoid squamous cell carcinoma. Okay, nest of the tumor cell separated by the fibrous bands over there. Tumor typically located near the hilus, projecting into bronchi. Bronchoscopic view of this tumor is over there, and we can also find the tumor in the chest X-ray. Bronchogenic carcinoma may lead to, number one, thoracic outlet syndrome. It can cause pressure on the lower trunk of the brachial plexus, that is C8 and T1, and subclavian artery by the cervical rib or Pancoast tumor. It results in the pain down the medial side of the forearm and hand, and okay, so it may result in pain down the medial side of forearm and hand and the atrophy of the intrinsic hand muscles. Number two, it can cause Horner syndrome, that is miosis, ptosis, and hemianhidrosis. Hemi means on the ipsilateral half of the face. So miosis, constriction of the pupil due to the paralysis of the dilator pupillae muscle. Ptosis, drooping of the eyelid due to the paralysis of the superior tarsal muscle. And hemianhidrosis is loss of sweating on one side. So the half side of the face, like I guess this half of the face, this side. So this side of the face will lack the the sweating. So there will be no sweating on this side of the face, and there will be flushing on that side. Bronchogenic carcinoma may lead to superior vena cava syndrome. That is very important. Here you can see the superior vena cava is being compressed over here. In this picture you can see the compression of superior vena cava. So what are the symptoms which are associated with the superior vena cava syndrome, which can cause dilation of the head and neck veins? Okay, so you will find the distended jugular veins. Yeah, the jugular veins will be distended bilaterally. If they are dilated ipsilaterally, so or unilaterally, so then you must suspect the obstruction is at the level of maybe in the brachiocephalic vein or maybe in the subclavian carotid vein on each side. So remember that if there is bilateral dilation of the jugular veins, so there is superior vena cava constriction going on there. Point 4, superior vena cava syndrome can be there. So that is the continuation. First one was thoracic outlet syndrome, then Horner syndrome, then we were talking about superior vena cava syndrome. Now dysphagia can also be seen as the result of esophageal obstruction by the tumor, if that tumor is going to obstruct, because all the mediastinal structure are at risk of being compressed. So if the esophagus will be compressed, there will be dysphagia, hoarseness as a result of recurrent laryngeal nerve involvement, paralysis of the diaphragm as a result of the phrenic nerve involvement can also be seen. because of the involvement training. Okay, what are the sites of lung auscultation? To listen to the breath sounds of the superior lobe of the right and left lung, the stethoscope is placed in the superior area of the anterior chest wall above the fourth rib for the right lung and above the sixth for the left lung. So that is horizontal fissure over here. So if we are willing to auscultate the upper lobe, so we have to keep the stethoscope above this fourth rib on the right side and above the sixth rib on the left side. For breath sound from the middle lobe of the right lung, the stethoscope is placed on the anterior chest wall between fourth and sixth ribs. So between the fourth and sixth rib, we are going to auscultate the chest on the right side. For the inferior lobe of both the lungs, breath sounds are primarily heard on the posterior chest wall. For the inferior lobe of both the lungs, the breath sounds are primarily heard on the posterior chest wall. So inferior lobes are auscultated posteriorly, while the superior and middle lobe can be auscultated anteriorly. The superior lobe on the right side should be auscultated above the fourth intercostal space. On the left side, it must be auscultated above the sixth intercostal space, right? The middle lobe that is present only on the right side, that must be auscultated on the right side between fourth and sixth intercostal space, and the inferior lobes of both the lungs should be auscultated posteriorly. Okay, then here you can see the extent of the inferior lobe posteriorly. So it is extended, like here it is inferior, but then it extends all the posterior wall as well. So remember this thing, that posteriorly you are either auscultating the superior lobe or the inferior lobe. The middle lobe does not go back. Open pneumothorax pleura. What? Open pneumothorax. First one is pleura. So point number 31. So it is the entry of air into the pleural cavity causing the lung collapse. So here you can see in this picture that the lung has collapsed, and in this picture you can see that this opacity is lung and the black area is the air that is present in the pleural cavity. So it is the entry of air into the pleural cavity causing the lung collapse of open pneumothorax. So what is open pneumothorax? Open pneumothorax due to stab wounds or thoracic wall which pierce the parietal pleura so that the pleural cavity is open to the outside air via the lung or through the chest wall. Air moves freely through the wound during inspiration and expiration. During inspiration, air enters the chest wall and the mediastinum will shift towards the other side. That is very important, that when the air is entering during inspiration, air enters the chest wall and the mediastinum will shift towards the other side and compress the opposite lung. During expiration, the air exits the wound and the mediastinum moves back towards the affected side. So that is in the case of pneumothorax, when the chest is expanding and there is negative pressure, increased negative pressure in the pleural cavity. So the air will move inside and this will push the trachea and mediastinum to the opposite side, and when the air is moving outside, or when there is positive pressure, like relatively positive pressure, so the air will be moving outside and the mediastinum will move back. But it is not true in case of tension pneumothorax, if it is written over there or not. So in the case of tension pneumothorax, the thing is that air can just enter inside. There is a flap like movement on the site of entry, so the flap moves, the flap allows the air to move inside but does not allow the air to move outside. So resultantly, in the case of tension pneumothorax, the trachea is moving to the contralateral side, and that is a very serious kind of medical emergency, and you have to manage that as soon as possible. Then talking about pleura and pleural cavity, number one is cervical pleura, like over here. So cervical pleura may be affected in case of improper subclavian venipuncture. It results in pneumothorax. Okay, so if there is some venipuncture which is done over there for some procedure and you inadvertently damage this parietal pleura over there, so you can result in pneumothorax. Costodiaphragmatic recess, the point 2, this one is a costodiaphragmatic recess, is the deepest place in the pleural cavity around the chest wall. There are two rib interspaces separating the inferior limit of the parietal pleural reflections from the inferior border of the lung and the visceral pleura. What's there? There are two rib interspaces. Okay, so like how many? There are a lot of them. 1, 2, 3, I don't know. Okay, so this is the, I guess, 8th rib and then the 10th rib. So there are two ribs interspaces. Okay, so this must be the 8th rib and this must be the 10th rib. So there are two rib interspaces separating the inferior limit of the parietal pleural reflection from the inferior border of the lung and the visceral pleura. Okay, mid-clavicular line between the 6th and 8th rib, the mid-axillary line between 8th and 10th, typically placed for the thoracocentesis, and the paravertebral line between the 10th and 12th rib. So mid-clavicular line, at mid-clavicular line, the two spaces are between 6 and the two ribs interspaces are between 6th and 8th rib. In the mid-axillary line, it is between the 8th to 10th rib, and in the paravertebral area it is between 10th to 12th rib. So there is always two disc space between the inferior part of the lung and the reflection of the parietal pleura, and at different positions, at different locations, and different lines, they look something like this. Then you have nerves of parietal pleura. So the parietal pleura is sensitive to the general sensibilities, pain, temperature, touch, and pressure. There we receive the somatic sensory innervation. Costal pleura, the intercostal nerves, the parietal pleura is like over here. Somatic sensory information. Okay, so listen. Then we have costal pleura. So parietal pleura is subdivided into costal pleura, mediastinal pleura, and the diaphragmatic pleura. The costal pleura is the costal pleura. Intercostal nerves block may be used to decrease the thoracic pain from the costal pleura. So suppose it is a lung over here, like this, and it is surrounded by the pleura. So on all sides it is having the parietal pleural covering. So the covering that is around, the ribs are there and the thoracic wall. So the parietal pleural layer that is adherent with the thoracic wall, that is costal pleura. Then we have the mediastinal pleura. Phrenic nerves are supplying the mediastinal pleura, and mediastinal pleura is over here, like in the mediastinum. It is lining the mediastinum, you may say that. So phrenic nerve, and then diaphragmatic pleura, the pleura that is present just over the diaphragm. So the diaphragmatic pleura is supplied by the phrenic nerve over the domes of the lower 6 intercostal nerves around the periphery. So the phrenic nerve will be supplying over the dome and the lower 6 intercostal nerves around the periphery. Okay, what is about visual pleura? Sensitive to stretch but insensitive to general sensibilities. Autonomic nerve supply from the pulmonary plexus. So the visual pleura is sensitive to the stretch, but it is insensitive to the general sensibilities, which are autonomic nerve supply from the pulmonary plexus and all that. Moving to the point number 32, that is mediastinum, superior mediastinum. So let's talk about superior mediastinum first. So the superior mediastinum, the sternum is a common site for bone marrow biopsy. Okay. Improperly done sternal puncture may affect the structure related to the posterior surface of the Menobrium sternum, which are definitely in the anterior mediastinum. No, that is the superior mediastinum. Okay, so let's talk about this. This is an independent topic. So the sternum is a common site for bone marrow biopsy, and in improperly done sternal puncture may affect the structures related to the posterior surface of the Menobrium sternum. Number one is the upper part of the left brachiocephalic vein. The left brachiocephalic vein is over here. So this left brachiocephalic vein can be punctured. Number two is in the lower part, aortic arch can be damaged. Okay, so the aortic arch can also be damaged. Okay, so the aortic arch is over there. So I guess the most common site is the Menobrium then, because both of these structures are lying behind the Menobrium. But just keep this in mind that always take good care when you are taking a biopsy for the bone marrow from the sternum, because you have a chance of damaging these two structures which are lying immediately behind the sternum. So these are also the members of superior mediastinum. The brachiocephalic vein and the aortic arch, both of them are present in the superior mediastinum. Another structure that is present in the superior mediastinum is the thoracic duct. So remember, this is the right side and here we have the left side. So function of the thoracic duct is that it conveys to the blood all lymph from the lower limbs, pelvic cavity, abdominal cavity, left side of the thorax, left side of the head and neck, and left upper limb, 3/4 of the body. So basically 3/4 of the body. Everything below this line, I don't know the level. So both the lower limbs and umbilicus and abdominal cavity and the left side of the thorax, so even the left side of the thorax and left heavy section of the face and neck and even the left upper limb, all of that limb is going into the thoracic duct and then into the blood supply, right? Side of the head and neck and left upper limb. Okay, so tributaries of the thoracic duct are root of the neck. Tributaries are at the root of neck, the left jugular lymph trunk, the left jugular lymph trunk, left subclavian lymph trunk, and the left bronchomediastinal lymph trunk. So these are the three tributaries, the main tributaries which are present at the root of the neck: the left jugular, the left subclavian, and the left bronchomediastinal lymph trunks. So the thoracic duct is draining mainly the left side of the body. For the right upper half of the body, including the right upper limb and the right face and neck, I guess we have right thoracic duct or something like that. So the main thoracic duct is draining the left side of the body. That's 3/4 of the body, you may say that as well. Constrictions of the esophagus. So there are normal constrictions of esophagus at 1, 2, 3, three main sites. So let's see them. There are sites where ingested foreign bodies can lodge or where strictures may develop following the ingestion of caustic fluids. Common site of esophageal carcinoma are also these constrictions. So number one is at the level of cervical, sixth cervical vertebra, where the pharynx joins the upper end, 6 from upper incisors, 6 inches or 6 feet maybe. So 6 feet or 6 inches from the upper incisor. 6 inches is the right thing. So 6 inches from the upper incisor, we have C6, and that is the first point of the constriction. With the pharynx joins the upper end. Okay, so the junction of esophagus and pharynx is the first constriction. Secondly, at T4 or T5 level, where the aortic arch and left main bronchus cross its anterior surface, that is 10 inches from the upper incisors. So at the level of T4 or maybe T5, where the aortic arch and the left main bronchus, this is the left main bronchus, so they are crossing the anterior surface. So at that particular position, there can be a constriction in the esophagus. And then at the level of T10, where it passes through the diaphragm into the stomach, that is 16 inches from the upper incisor. I don't know why it is important. So 6 inches, then 10 inches, and then 16 inches. So these are the three levels of constriction, that is C6, T4 to T5, and T10. So these three constrictions are the sites where the foreign bodies can get stuck, where strictures can form, or where esophageal carcinomas can develop. Then we have anterior abdominal wall over here. So this is the anterior abdominal wall. There's a vertical plane and the medial plane. There we have the descending colon and the sigmoid colon as well. So the liver and gallbladder are in the right upper quadrant in the anterior abdominal wall when we are palpating. So we must remember that the liver and gallbladder are over here. Like this is the liver and the gallbladder. The stomach and spleen are in the left upper quadrant. Stomach and the spleen are here in the left upper quadrant. The cecum and appendix are in the right lower quadrant. Cecum and appendix are over here in the right lower quadrant. They have divided the anterior abdominal wall into 4 quadrants, but normally we divide that into 9 quadrants. We'll see that later maybe. Okay, so the end of descending colon and sigmoid colon are in the left lower quadrant. As you can see in this picture, they're in the left lower quadrant. Referred abdominal pain. It is very important side. We have seen that in the GIT section when we were doing the first aid sessions. So they are the very first aid sessions I did on my channel. So go watch them as well. So let's see it here. The pain arising from the foregut derived structure is referred to the epigastric region. This is the epigastric region. So let's talk about the region first. This is the epigastric region. These are the I guess hypogastric regions, both of them hypogastric regions. This is the umbilical region. Then we have the lumbar regions or the flanks. Then this is the hypogastric. This is the hypogastric. These are not hypogastrics. Give me a second. So yes, here you can see it is epigastric, then left hypochondriac, right hypochondriac, then umbilical region, left lumbar, right lumbar, and then hypogastric, left inguinal, and the right inguinal region. So these are the names of these regions. Coming back to our PDF. So here we have epigastric, hypochondriac regions, umbilical, and the flank or the lumbar regions, and the hypogastric and the inguinal regions. So removing this all, so here you can see that if there is pain arising from the foregut derived structures, it is referred to the epigastric region over here. What are the foregut derived structures? The foregut derived structures include the I guess the structures which are before the second part of the duodenum. Yes, the second part of duodenum is a part of the foregut. Then from the so here you can see in this picture, these are the derivatives of foregut, which start from the pharynx, then the lower respiratory system, the esophagus and stomach, duodenum distal to the opening of the bile duct, including the liver, biliary apparatus, hepatic ducts, gallbladder, bile ducts, and the pancreas. All of that is the derivative of foregut. Then for the midgut, the referred pain is going to the referred pain, the pain arising from the midgut derived structure is referred to the umbilical region, that is this region, right? And the midgut include the third and fourth part of the duodenum, along with the jejunum and ileum, including the ascending colon till the proximal 2/3 of the transverse colon. The pain from that region is going to the umbilicus, is referring to the umbilicus, and you must remember that the appendix is a midgut derivative. So the pain from the appendix initially is felt on the umbilical area, and then when the appendix enlarges, too much, so the parietal pleura gets stretched. Not pleura, parietal peritoneum. Sorry, parietal peritoneum gets stretched, and due to the stretch of the parietal peritoneum, the pain is then felt or referred to the McBurney point. So the pain is then radiating to the McBurney point over there. So let's forget about that. Then we have this region that is called as the hypogastric region. So pain arising from the hindgut derived structure is referred to the hypogastric region, and the hindgut derivatives are all the gut distal to the transverse 2/3 of the like distal 1/3 of the transverse colon and all the way down to the rectum above the pectinate line, that is coming from the hindgut. Nerve supply of the anterior abdominal wall. So this is the nerve supply. We saw the dermatomes previously. The T7 is at the xiphoid process level, T10 is at the umbilical process level, T4 was at the nipples level. So, but that is not a part of the anterior abdominal wall, so we'll omit that. So T7 is at the xiphoid process, T10 at the umbilical process, and the groin, L1 supplies the groin region. So let's see that totally. Therefore, what nerve supply of the total abdominal wall? Now there's a continuation of that. Therefore, totally 7 nerves. It's not a continuation. That's, I guess, ambiguous point. So therefore, totally 7 nerves, lower 5 intercostals, 1 subcostal, and L1 iliohypogastric ilioinguinal nerve supply the anterior abdominal wall. The total 7 nerves that are supplying the anterior abdominal wall. Lower 5 intercostal, that is T6, 7, 8, 9, 10, 11, 10. 5 intercostals. But 11, 12 are also there. So 1, 2, 3, 4, 5, 6. So should we start from T8 maybe? So if we start from T8, but this 1, 2, 3, 4, 5. Yeah. So the lower 5 intercostals, 1 subcostal, and L1. So the T12 is subcostal then. So we are starting from T7. 1, 2, 3, 4, 5. These lower 5 intercostals, the T12 is subcostal nerve, and L1, that is iliohypogastric and ilioinguinal. Iliohypogastric and ilioinguinal nerves supply the anterior abdominal wall. Then we have L1 can be anesthetized by injecting 1 inch 2.5 centimeters superior to the anterior superior iliac spine. So if we inject anesthesia 1 inch superior to the anterior superior iliac spine, that is somewhere over here, we can anesthetize the anterior superior iliac spine and ASIS. Okay, so anterior 1 inch above that, giving the injection, we can anesthetize the L1. Okay, all the nerves and deep blood vessels in the neurovascular plane between the internal oblique and the transversus muscle. All the nerves and deep vessels lie in the neurovascular plane between the internal oblique and the transversus muscles. Anterior supply of the anterior abdominal wall. Arterial supply of the anterior abdominal wall. Important superficial arteries that supply the skin are superficial epigastric arteries, which are over here. So they're superior epigastric, superficial epigastric, and superficial circumflex iliac arteries. They are supplying the superficial arteries. Important deep arteries lie in the neurovascular plane. Number 1 is superior epigastric, over here superior epigastric, then posterior intercostal arteries. Okay, lumbar arteries, deep circumflex iliac arteries, and inferior epigastric arteries. So superior and inferior epigastric, along with posterior intercostal, lumbar, and deep circumflex iliac arteries. So these are deep arteries, and superficial arteries include superficial epigastric and superficial circumflex iliac arteries. What are the body wall defects? Number 1 is omphalocele. Omphalocele involves the herniation of the abdominal viscera through an enlarged umbilical ring. Viscera are covered by the amnion. So omphalocele. Okay, got it. So in the omphalocele, you may remember that the viscera are covered in the O of the omphalocele. This O of the omphalocele, like the viscera will be covered in the in this thing, that they will be covered in the peritoneum. Not peritoneum, they will be covered by amnion. So here you can see amnion is covering the viscera, and then we have a continuation of the umbilical cord. In the case of gastroschisis, it is a herniation of the abdominal content through the body wall directly into the amniotic cavity. Viscera are not covered by the peritoneum or amnion. So here you can see the viscera are not covered by amnion, and that is most commonly on the right side of the umbilicus due to some unknown reason, but that is most commonly on the right side of the umbilicus. Then we'll talk about herniations. Hernia consists of 3 parts, 1, 2, and 3. Hernia sac is a pouch or diverticulum of the peritoneum and has a neck and a body. Okay, so hernia sac, the black one, is the peritoneal outpouching. Okay, so it is a pouch or diverticulum of the peritoneum that has the neck and a body, and that contains the herniated content. The hernial contents may consist of any structure found in the abdominal cavity, more often the loops of small intestine, and pieces of omentum major. Okay, larger omentum can also be a part of the herniated content. Hernial covering are formed by the layer of abdominal wall through which the hernia sac passes. So there are 3 things. Number 1 thing, that is a hernia pouch. Then hernial contents, which can either be intestinal loops or anything, including the greater omentum. Then the third thing is the covering. That is hernial covering are formed by the layers of the abdominal wall, like skin, subcutaneous fascia. They will be covering, along with the fact that depends on the abdominal wall through which the hernia sac passes. So it is dependent on the layers which are passed by the hernia that they will be covering the hernial sac. We'll see that later on in the discussion. So transverse salis fascia is the first structure which is crossed by any abdominal hernia. So no matter what abdominal hernia is it, the first fascia or the first structure to be traversed will be transverse salis fascia. So here you can see this is the transverse sallis fascia. Over here, this one thing is transverse sallis fascia. Here you have peritoneum. So any kind of inguinal hernia is going to traverse the transverse sallis fascia. The very first one is inguinal hernia, indirect inguinal hernia over there. So in indirect inguinal hernia, remember, it moves into the inguinal canal, and that when it moves into the inguinal canal, it will traverse the deep inguinal ring as well as the superficial inguinal ring, and it most commonly enters the scrotum. So it is between the tunica vaginalis and the internal spermatic fascia. So this is a normal structure. The normal structure looks something like this. And then we'll talk about the indirect inguinal hernia. So indirect inguinal hernia is most common form of hernia and is believed to be congenital in origin. Boys 0 to 3 years. It passes through the deep inguinal ring lateral to the inferior epigastric vessel. So it is very important. The inguinal hernia, indirect inguinal hernia, lies lateral to the inferior epigastric vessels. So lateral to the inferior epigastric vessels, inguinal canal and superficial inguinal ring, and descends into the scrotum. So it passes through the deep inguinal ring. Forget about these red lines. It passes through the deep inguinal ring, inguinal canal, superficial inguinal ring, and descends into the scrotum. So it is passing through all these structures. Number one is deep inguinal ring, then it moves into the inguinal canal, then it passes through the superficial inguinal ring, and ultimately descends into the scrotum. So this is the pathway that is followed by the indirect inguinal hernia, and it is lying lateral to the inguinal ring. There is a mnemonic that is MDs don't lie. So that the direct inguinal hernia is medial to the epigastric vessels, and the I is for the indirect inguinal hernia. So indirect inguinal hernia is lateral to the epigastric vessels, inferior epigastric vessels. Okay, and indirect inguinal hernia is about 20 times more common in males than in females, and nearly 1/3 are bilateral. Then it is more common on the right. Normally, the right processus vaginalis become obliterated after the left. So if it is unilateral, although 1/3 of them are bilateral, but in case it is unilateral, so it is more common on the right side because the right processus vaginalis become obliterated later or after the left one. So the right testis descend later than the left. So right testis descend later than the left. Right processus vaginalis obliterates after the left one. So there is a chance of development of inguinal hernia on the right side. Then we have direct inguinal hernia. So direct inguinal hernia crosses directly through the superficial inguinal ring. It does not pass through the deep inguinal ring, and also it is not passing into the inguinal canal. Direct inguinal hernia composes about 15% of all the inguinal hernias. During the direct inguinal hernia, the abdominal contents will protrude through the weak area of posterior wall of the inguinal canal medial to the inferior epigastric vessel. So they will protrude through the weak area of posterior wall of the inguinal canal medial to the inferior epigastric vessel in the inguinal Hazelback triangle. So the indirect inguinal hernia was in the inguinal canal, while the direct inguinal hernia is into the Hazelback triangle. And after that, through superficial inguinal ring, it never descends into the scrotum. It never descends into the scrotum. It is a disease of old men after 60 years old with weak abdominal muscles. Direct inguinal hernias are rare in women and most are bilateral. So the direct inguinal hernias is a problem of adult or geriatric population, while the indirect inguinal hernia is thought to be a congenital problem because that is occurring in pediatric age group like 0 to 3 years. So then we have like both of the direct and indirect inguinal hernia are more common among men. And then we'll talk about femoral hernia. Okay, we'll not talk about femoral hernia, but femoral hernia are more common among females. Then moving forward to the point number 35, that is about the peritoneal structures. Number one is lesser omentum. So the lesser omentum is going to attach to the lesser curvature of the stomach. So lesser omentum consists of two ligaments, that is hepatogastric ligament and hepatoduodenal ligament. So hepatogastric ligament, like this is liver. So the ligament that is connecting the liver to the stomach is the hepatogastric ligament, and the ligament that is connecting the liver to the duodenum, that will be hepatoduodenal ligament. Contents: right and left gastric vessels, they are present over here on the lesser curvature. So they are anastomosing of the lesser curvature, and lesser curvature is the site of attachment of the hepatogastric ligament. So they are present inside the hepatic ligament, we can say that. The connective and fatty tissue and the portal triad is present in the hepatoduodenal ligament over here. You can think of it like over here, this is hepatoduodenal ligament, and the content of hepatoduodenal ligament is the portal triad, which includes the bile duct, the portal vein, and the proper hepatic artery. Got it? Then we have epiploic or the Winslow's foramen. What is that? So there is a foramen, just adjacent to the hepatoduodenal ligament. Here you can see this foramen. The arrow is showing the gastroepiploic foramen. So the epiploic or the Winslow foramen anteriorly, the free border of the hepatoduodenal ligament containing the portal triad, that is duct, vein, and artery. So bile duct, the vein, the portal vein, and the hepatic artery. Posterior to this portal triad, posterior to the epiploic or Winslow's foramen, we have inferior vena cava. Anterior to that, we have caudate lobe of the liver, and inferior to that, we have first part of the duodenum. So remember these things, that these are the relationship of the epiploic or Winslow's foramen. Anteriorly, the free border of the hepatoduodenal ligament contains the portal triad, that is the duct, vein, and artery. Posteriorly, we have inferior vena cava. Superiorly, caudate lobe of the liver is present, and inferiorly, the first part of the duodenum is present. Then we have to talk about the Douglas pouch. Okay, this is the last topic, and then we'll continue the rest in the next session. So Douglas is the recto-uterine pouch. So here you can see the recto-uterine pouch of the Douglas, deeper point of the peritoneal space in the vertical position in the female's body between the rectum and the cervix of uterus. It is the space of pelvic abscess location. So pelvic abscess is basically located in the, so there are a lot of structures that can be present in this thing. So remember that the peritoneum is moving in the abdominal wall, then it moves backward over the roof of the urinary bladder, and then it is reflected on the uterus. So there is also a vesico-uterine pouch over there, but that is not something that we are talking about right now, so forget about it. Then it moves over the uterus, and then from the posterior wall of the uterus, it is reflected on the anterior surface of the rectum. So when it descends on the anterior surface of the rectum, there is a pouch that is formed between the uterus and the rectum, and that pouch is called as a recto-uterine pouch of Douglas. So recto-uterine pouch of Douglas, deeper point of peritoneal space in the vertical position in female body between the rectum and the cervix of the uterus. Okay, so it is between the rectum and cervix of the uterus. So this cavity is this is the vagina. So this cavity is cervix over here. Okay, so this thing is cervix, like this one. So it is the space of the pelvic abscess location. So pelvic abscess, even if the pelvic abscess can be located over there, even some ectopic pregnancies can be found in this position. In some cases, we can also find maybe another thing, endometriosis. Yeah, endometriosis can be found in this place. So there is a lot that can fall all the way. Some metastasis can see to this place. So there is a lot that can fall into the pouch of Douglas. So remember this pouch. After that, we have to do the Culdo synthesis. We will do that after the break, inshallah. Until then, Allah Hafiz and Fi Aman Allah.